Welcome to the Doctor's Take on Aesthetics, and I am joined today by none other than one of the best cosmetic doctors in Sydney, Dr. Robert Laidlaw.
Thanks, Dr. Wall. Thank you very much for the introduction, and thanks for having me here today.
It is my pleasure, mate. It's great to have you here. Now, we want to talk about something really topical at the moment. Now, there is a lot of confusion out there about the new guidelines surrounding cosmetic surgery, cosmetic medicine. Now, in terms of the cosmetic surgery, there's been a lot of changes. So if you want to see a surgeon to get some kind of major procedure, so whether it be a breast lift, facelift, something like that, you need a doctor's referral now. As you were saying, Rob,
do I need a referral from my GP to get my Botox done?
You don't.
That's what everybody's been asking me. My mum's been asking me, my friends, even GP friends have been confused about this. So
yeah,
I think...
Look, when the first submissions come out, when the first guidelines got released, it was really hard to know because it kind of did intimate that you did need one, but APHRA's cleared that up now, and you do not need a GP referral to get a Botox treatment. But in saying that, everyone should see their GP every year anyway. I mean, it's very important to get regular health checks, and especially if you, I mean, we'll touch on this later on, but some people have some issues with body dysmorphia,
Yep.
and they may be instances where we would insist on seeing your GP before. Now, I've got to say, hats off to APHRA. This has been a long time coming. This industry, especially, we'll talk mostly about cosmetic medicine, but it's the Wild West out there. I mean, you or I, we watch Instagram videos all the time.
Yeah.
I mean, we saw one the other day of an under-chin fat dissolving injection, and it's just wild how some people do it.
I'm sure everybody's seen on the news and on current affair about the liposuction and the dancing. That's
Yes.
everyone's mind. It's the same sort of thing, really. But
Yes.
it happens in cosmetic injectables just like in surgery.
No, and it does. And that is a very shocking thing to look at. So people dancing while doing cosmetic surgery, people talking to a camera while not looking at the instrument. That is not a very good look. What I'm more concerned about, though, is that there are so many unqualified practitioners out there. So can you tell us a little bit about, say I'm a nurse, I'm 2 days away from finishing nursing school. How can I start injecting?
You basically, I think you do a course. It could be a weekend course
Yeah.
or a boot camp for a week, and
Yeah.
away you go. You can
Away you go.
jump on your phone and get a third-party prescribing, find a doctor, dial a doctor,
Yes.
get your product, and away you go. All by yourself in your backyard or in front of your house.
Yeah.
And it's a bit scary, really.
I mean, look, it's really, really frightening, and I'm glad that these changes may be coming in because the consumer, they just don't know. They do not know who they are going to see. So they could come and see some of our colleagues who are in their 60s. They've been doing this for 30 years. I mean, you or I have been doing this for 10 years. Or you could see a nurse down the street that's working out of the back of a hairdresser that charges the same as you and I,
Yeah.
who done a weekend course that actually is not recognised by any regulatory authority,
Yeah.
and they have no doctor oversight. Now, there are businesses out, I mean, why don't you tell me about the businesses out there that script these nurses, that allow them to practice like that?
I mean, there's been a booming industry now. You just do a search on the internet, there'd be dozens of them now, ranging from like $15 or $20. They jump on an app, takes 2 minutes. You have a nurse in Potts Point getting their fillers from, an intern in Perth who's never had any experience with this stuff. Who just
Exactly.
wants to make a bit of money on their side hustle, different time zone.
Yeah.
I think what worries me more than anything is that if anything goes wrong, like having access to the doctor is really, really important.
Yeah.
So it's one thing to do the prescription, but with that prescription becomes a lot of other responsibility. Like,
Of course.
if there's a vascular occlusion, if there's an infection, et cetera, et cetera. Having it on the end of the phone for a quick little consultation like that makes it really difficult.
And this doctor that's doing the script,
Yeah.
how much experience do they have in cosmetic medicine?
But they don't have to have any, to be honest.
I would say most have none.
Yeah.
Zero experience.
I used to be a scripting doctor, as I'm sure you probably were back in the day.
I do remember.
I must confess, I had very little experience when I was a scripting doctor. It's
Exactly.
usually the very junior or, I guess, early people that get these jobs,
Yeah.
ironically, when they should really be the most experienced.
And, I mean, you've got some of these scripting doctors. There is a nurse in Sydney who's getting scripted by a doctor in Perth who has zero experience in cosmetic medicine, and that doctor I've seen some doctors do 800 scripts a day. I mean, that is wild. That is ludicrous.
You don't need to be a mathematician to know that they're spending very little time with each patient. So, the AMA's got guidelines, the TGA's got very clear 12 points that you should cover in all the scripts, taking a history, making sure it's the right treatment, the right product, financial consent, etc. Even if you spent just 1 minute with all those things, that's 12 minutes. If they're doing 800, I mean, you don't need to be smart to know that's just not possible.
I mean, clinics only stay open for 10, 12 hours a day. So
tick and flick, sign here, next $25, and round and round. I don't know if you realise, I was doing a bit of reading before this chat we had today. Telehealth or prescribing actually first done in the 1800s.
Really?
And it was done via telegraph. And it was done from like doctors that were out in the bush.
Yeah.
And they would sort of send messages and allow the bush nurse to do life-saving treatments.
Yes.
It's evolved obviously as technology with phone calls and now videos and things. But it was never designed for inner city nurse practices doing sort of cosmetic things.
Definitely
It's designed for life-saving stuff for rural people.
Exactly.
And I really do feel like it's being exploited. I know at Contour Clinics, I know we do use telehealth, but it's with our own doctors inside. And I think that's the difference that's really important. Like before somebody's going to say, oh, well, that's what we do. But we have our own doctors that we know are trained, that can follow the patient up if needed or see them face-to-face if something was to go wrong.
I mean, here's the whole thing. So with Contour Clinics, we're having to self-regulate because the regulations just aren't there. I mean, I would find anything other than a doctor on site not good enough. Because if you do have a vascular occlusion, if you do have some kind of disaster that happens, now, what people forget is these are medical treatments. So these are S4 medications that have to be prescribed by an APHRA registered doctor, okay? These aren't benign facials. Whilst the risk of these is incredibly rare, and if it's done in the right hands, the risk should be even smaller, there is a risk nonetheless. I have friend nurses that work out on their own, and they do not know how to do a reversal agent at all. And I get calls all the time from colleagues that are out working on their own. And I just feel, we talked about scope of practice before. Now, I as a doctor, you as a doctor, we've got a Bachelor of Medicine and a Bachelor of Surgery. We can go out and do breast augmentations tomorrow, but it's not within our scope of practice. No. We haven't done the necessary training. I do not think it's fair that I go and do that to a patient purely for profit. And I feel like these scripting services that are out there, you cannot tell me that a script being done in Perth for a treatment happening in Sydney is about patient safety. That is purely profit. And I think that I cannot welcome these new rules that are going to come in enough, because we need to protect patients from this kind of behaviour, this kind of profiteering. At Contour Clinics here, there is always a doctor on site, and all of our nurses are incredibly trained. The other thing that I'll add to that is that when you finish nursing school, like you mentioned before, day one after finishing nursing school, you can go and inject. What about being a doctor?
No, you're the slave for 12 months internship.
You need to go and do an internship for 12 months.
And get paid a pittance.
Minimum 8 to 9 years of uni, and then I have to go and do a year before I can then inject.
Well, you're watched like a hawk for the whole time.
Watched like a hawk while we're doing this. Nurses, 0. Leave nursing school, go straight into it.
And the regulators recognise this is why they need to get a prescription from a doctor.
Exactly.
And it's also why the insurers realise that, and
exactly.
why doctors' insurance is tens of thousands of dollars.
It is.
And nursing insurance is hundreds of dollars, because the risk and responsibility is not on them, it's on the prescribing doctor.
But I feel the problem at the moment is that the nurses are taking all this responsibility on. I would question if the insurance is valid from the doctors that are doing the scripting. I just worry at the moment we're moving away from profit, away from patient care, and more towards profits. And I think that it is very, very important that we kind of steer back into that.
It's certainly something that I'm very interested in, to be honest. I know I have a lot of close friends and family that suffer from this terrible thing. So
Yes.
it's something I've got a lot of experience firsthand, and how devastating it can be for everybody.
Yeah.
Look, I don't want to be a problem announcer without some sort of problem-solving suggestion. I know that we here screen patients, the intake team screens them, and that's
Yes.
helpful. Again, reading a little bit about, there are actually services now that whether you can sort of implement that into your practice, where they do that for you. Look, I'm not sure what the right answer there is, but I think there's more awareness. I'm certainly seeing it talked about more, and I think the more we talk about it, the better. I'm not sure what your thoughts are.
Look, mate, I think body dysmorphia is really common. And I think when you engage in getting a cosmetic treatment, you often become slightly body dysmorphic. I mean,
Absolutely.
I've had it myself where... So you may be someone who, you look at your face in the mirror each morning. You don't really think much of it. You put your makeup on, you wash your face, whatever. But when you get a cheek filler, when you get a lip filler, you start to obsess about it a little bit. You start to think, oh, hang on, is that even? Is that asymmetrical? I mean, I've got a good example for you where I become one of those people once, where I had one of our nurses do a treatment that
Who was it?
my folds. Well, I'm not going to throw them under the bus, but I could have sworn that she made all of this bigger, and I look back on a photo 10 years before and I had it there.
And I mean that's whenever I have the new staff that I'm teaching in my clinic, I always emphasise the importance of before and after photos. I know it's
100%.
classic cosmetics 101.
100%.
It's saved my soul that many times.
Yes.
Where people have come in exactly what you've said.
Exactly.
I brought up their before photos and it was already there.
Yeah,
But often they haven't obsessed about their face as much until they've had their first treatment.
definitely. You definitely obsess about your face after this.
I know
And
you've
it
got a
is
psychology
completely
background,
normal.
so you probably got more insights into this, but I imagine it's a spectrum, isn't it? It's sort of...
Of course. I mean, look, true body dysmorphia, any psychological disorder has to be present for at least a certain amount of time. You have to think about it at a certain time of the day, every day. I think there's also a bit of a misunderstanding of body dysmorphia. So you may see a girl or a guy walking down the street and they look pretty overfilled, and you think, oh, God, that doesn't look very good. Now, I've never been one to push my idea of aesthetics on someone. So, if you want those really big lips, that's not my look.
Who are you to judge?
But who am I to judge? So, what my assessment is for that is, one, is it safe to put more filler in? So, am I going to do you harm? First day of medical school for us, do no harm. That's the thing they drum into us, and all the way through our training, do no harm. So if I think, yes, I can put more in, yes, it's not going to cause them physiological damage, and I've assessed them mentally, is this going to do them harm mentally? Then I think it's okay to do it. All right? But that's not my specialty either. We have doctors that do the more kind of fake look. Some people like that fake look. And I guess what it is, it's about not judging, and it's about doing a proper body dysmorphia assessment.
I think it's probably worthwhile noting that not only are you a star on Channel 10 on the telly, but he's also our medical director has a psychology degree too. So I think it's a really valuable thing for the company.
Yeah. Well, look, I mean, it's just being sensible about it. I've got actually quite a funny story about. We had a really beautiful receptionist that worked for us at Newtown before, and she liked the fake look. She liked to have a lot of stuff done, and one of our patients come to her once and said, I like your lips. They look really natural. And she goes, well, I hope not. I've paid a fortune for them to look fake. So she does not, in that circumstance, have body dysmorphia. She knows she looks fake. She wants to look fake. It's not doing her any harm physically. And emotionally, it's not causing any damage. So I just think it's important to put patience over profit. And that kind of leads me on to another thing slightly different to body dysmorphia, is that you always want to provide patients value in every single instance. So whether they have some kind of trait towards body dysmorphia, bringing that up, that can be a very difficult thing to do.
It'd be triggering.
Oh, one of my biggest complaints here at Contour is when I tried in a very gentle way to broach the fact that, look, I think you're overthinking things, I think you may need to see a GP. And I mean, look, that's just part of the part. I mean, we all know first step of fixing a problem is admitting you have a problem, you know. And if you look at the stages of change, you know, pre-contemplation, contemplation, a lot of people are in that pre-contemplative phase. So I think it's important for injectors too to come up with some kind of strategy to deal with people, because one of the symptoms of this is a semi-loss of contact with the reality of the situation. You know, they might know. It's like the whole bodybuilder who thinks they're skinny.
Yeah.
You know, it is definitely a real thing. But going back to value, there are a lot of clinics out there that are, like, you've seen the fat freezing clinics and all those kind of things. Yeah. It's the perfect example of a profiteering. And here at Contour, what we do not sell any treatments that I can't show you a result with. You know what I mean? Because, I mean, you know what it's like.
And the photography is such a big part of every consultation.
Absolutely.
Everybody gets a 3D photo where you can look at yourself in different angles. We can then simulate it before you do it.
Definitely.
To see, try before you buy, almost.
Of course.
Without touching the patient.
Yes.
And I think it makes people a lot happier.
Yeah.
People aren't getting things done that they regret as much.
Yes.
And it's safer too.
And it's about managing expectations. I mean, you and I train a lot of our junior staff here, and day one of training, I tell people, cosmetic medicine is all about expectation management. That is the holy grail of cosmetics.
Under promise and over deliver.
Exactly. So, I mean, you love when you get the photos of the world's most beautiful lips, and I want to look like this, and it's about having that conversation with them. Your anatomy's different. This is the chance that I'll get there, I won't get there. Honesty is always the best when it comes to this. You want to go to a doctor or nurse that's going to tell you their opinion and not just push filler into you.
I think that's why certainly the patient's telling me that they choose us because we're trusted, because we've got doctors on side always.
Yes.
And they feel like some of the other sort of cheap and cheerful shopping centre places, it's rushed, profiteering.
Well, exactly.
It's not as trusted.
Exactly. I mean, my favourite line to patients when they come in, because, look, this is the unknown for a lot of people. There's a lot of taboo around the space. There's a lot of anxiety to come into a place like this. They've had all these unrealistic expectations put on them from social media, and they come to me thinking I'm going to change the world for them. And often what I have to say to them, I gauge their expectation, and then what I'll say is, look, I see your expectations as here, and what I can deliver is here.
Let's meet in the middle.
We need to bridge this gap. My skill is not going to get this much better in the next minute. So you need to come down to here. So, but I see a lot of practitioners out there that go, yeah, no worries.
So talking about value, it's an interesting point. We both very much agree that APHRA is doing a great job with this new consultation.
Fantastic.
What I would just really hope to see though is we're going to deliver some things that are going to make a real difference to patient safety without sort of creating unnecessary red tape and burden. Because ultimately, if there's a bunch of new rules that come out and we need to do a bunch of new paperwork or screening things that probably don't make any difference but make everyone feel a bit better, ultimately that's going to cost us as business owners more.
Yes.
And then ultimately cost the patient more.
We're going to pass that on to the patient.
And,
we have to.
You know, nobody wants that. We don't want that. Patient doesn't want that. We certainly want that if it's going to make a difference. But I think practical things that are going to have evidence behind making a difference is a great idea. And so I think scripting would be a great, easy win, really.
Well, look, I think this telehealth thing has to stop.
It's a very simple thing they could do overnight. Like
I just think it's a...
cosmetics ultimately is unnecessary. By definition, people come and say to me,
"Of course,
what doctor? What do I need?"
Why
I
not
always have the
cure
joke.
cancer?
I'm like, nothing.
Nothing. No one needs anything.
What? Don't need nothing.
No one needs anything. It's like a Ferrari. I'd like one, but I don't need one.
So we don't need telehealth for things that are unnecessary.
Exactly.
We do need it for diabetes.
Because like you said, telehealth was created for a nurse working out in Broken Hill where the doctor's 200 k's away and the nurse needs to give some atropine because a patient's heart rate's gone awry.
It's not for circumventing prescribing rules in Potts Point or Surrey Hills.
Exactly.
Or Newtown. Yeah.
Yeah, exactly. So it's not for inner city Sydney. That is not what the rule was created for.
At very least, having a doctor on site, I think
Yes.
would be probably a compromise that I'd be open to.
And look, in saying this, I'm not nurse bashing. Some of our best injectors here at Contour are nurses, definitely.
And many of them are much better injectors than me. I'm the first to admit that. But ultimately, like, these have to be rules for everyone. And
Exactly.
so whilst there are lots of great nurses, especially at Contour,
Yes.
that are at a high standard, these rules are for everybody. And
Of
so
course.
the graduates
I mean, we all need mentors,
through to the matrons.
so we've got the nurses here have us senior doctors. I consult with plastic surgeons, dermatologists, guys with a lot more grey hair than me, to when I need help. We all need that golden hand on the shoulder to make sure that everything is safe. It is all about patient safety. So I would, and going back to the thing before with nurses being able to come out of uni day one and inject, here at Contour, we don't let you work here unless you've had at least 2 years in the hospital. All of our nurses that have had at least 2 years in the hospital, they're out. They're all doing nursing jobs as well that has some responsibility. So they're working in emergency where they get to use their brain a little bit. They're working in intensive care where they get to use their brain a bit. They're the best nurses that we pick.
And they're all registered nurses.
And that's a good topic with the registered versus enrolled. Why don't you tell us a little bit about the enrolled?
Yeah, so just doing backgrounding from here. My partner's an enrolled nurse, so I've got to be careful what I say. But like, a lot of people want to do injecting as an enrolled nurse.
Yes.
And everybody's told me, oh, you definitely can't do it. And I probably just parroted that without actually looking into it. So I did look into it last night, and they actually are able to do it if a doctor's on site. The Nursing and Midwifery Board stipulates in their position statement on cosmetics that enrolled nurses must not do high-risk areas as defined as forehead, nose and temples.
Yes.
But otherwise they're allowed to. So, I mean, I think I won't get in trouble for saying. I mean, it's fact that enrolled nurses do a lot less time studying than
Well, how much
registered
time
nurses.
do they do studying?
I think it's a couple of years as opposed to, say,
I think it's like
4.
a year. I think it's a year.
18 months or a year, yeah.
18 months or a year.
Yeah, and a
And
registered nurse is 3 or 4?
3, I think.
3.
3 years. I may be wrong in saying that, but it's 3 or 4.
It's significantly more, though.
I think it's 3.
Yeah.
But here's the thing, though. The public doesn't know this. So you may come into a room and you may have someone with 1 day course who's done 1 year of training. And in that year of training, they've done 0 to do with cosmetics. Absolutely nothing.
What they should be doing is the contour course that's going to be coming out later in the year.
Absolutely, yes.
But that's a topic for another day.
Yeah, look, I just think things need to change with that. I mean, look, there's a lot of things that you don't learn anatomy in nursing. There's no way you learn facial anatomy. And look, even as a doctor, we don't learn facial anatomy the way we should. And all of us doctors here, we've gone off and spent years doing surgical training, learning anatomy, doing courses.
Yeah, what about something I think it's going to become more and more talked about as financial consent?
Definitely.
I think we do a great job here. I actually learned a trick from you,
Yes.
where I always had the consultation, we decide what we're going to do, and I bring it up on the computer as an invoice, and visually, like, it's one thing to say something. Sometimes people don't really register. I say it, but then I also show them on the computer, you're happy with this?
Definitely.
Because it does add up quickly,
Yeah.
especially, doing multiple meals and things. So we don't want to have bill shock.
And look, we like to give full plans as well. I mean, so you may do a treatment, say, for example, Profilo, which should get 3 treatments, and the first treatment's $950, and you don't tell them about the second or third treatment. So you really need to do financial consent in terms of what is your whole journey going to be. And I just find that I've just seen it done elsewhere. I think, so in terms of my recommendations for what should happen with all these changes, financial consent's a really big one. The telehealth is an absolute disaster at the moment, and it is only set up for profiteering. I mean, you've got some companies making $1 million a week doing scripts. I mean, it's out of control, and there is no justification for safety there. The other thing as well is just keeping a better eye on some of these profiteering businesses. Like, I mean, there's a very big case recently of one of these allegedly big companies that's doing this scripting selling fake filler.
Right. It's a bit concerning if you've got a company that's doing scripting that's got a lot of regulation and compliance. You would think they'd be across the details of, you know, what's needed for a registered product or registered medicine. So that's pretty concerning.
I mean, do you know how easy it is to look up if something's on the therapeutic register? It takes about 10 seconds on Google.
You can do it with your voice.
Yeah, so the ARTG, you can have a look. So if you're ever concerned with your injector, you think there's something going on with the filler. I mean, your biggest concern initially, if you've got filler they're offering for $250 a mil, everyone else is offering for $600, why? Ask yourself why. Okay? Because I know...
I've had some patients with Profilo, actually, that have said that they've been getting it in a city Chinese clinic for $250. I'm like,
of course.
That's less than we pay for it.
Well, that's less. It is definitely less than cost price. So
for anyone, not just for us, for anyone. So
yeah,
I said I would check that. I'd ask for some more information. You can always look it up. There should always be a patient implant card.
There should be
a lot number, an expiry date. I mean, most people wouldn't go before they get the filler and say, "Can I check the expiry date and the serial number?" But maybe they should.
I mean, so look, what we've done is we've made a web page on Contour Clinics, and we've made all the questions you should ask your injector to try and avoid some of these things. So I want my implant card, which has the lot number, the expiration. You want the name of the product, and we've listed how you can look all these things up. So the ARTG, the Therapeutic Good Register, and the Australian Therapeutic Good Register, you can go on and just type the product in, and it'll say whether it's registered or not. That's the first step. And you can, on APHRA Lookup, you can look up your practitioner as well, and you can gain an idea of what their skill level is. So are they a specialist? Are they a generalist? Are they a nurse? Are they an enrolled nurse? Things like that. So we've tried to, I mean, we like to open source all this stuff. We know that if we treat patients, we're a business like anything else, we need to make money. But we know that if we treat patients first, the money will follow. So our whole goal here is to make sure people are safe, make sure people are healthy. I always have this saying, I don't know if it's goofy or not, but I want my mum to come to this clinic and see any of our injectors, any of our therapists, and I don't have to stress. And I think that should be a goal of every single clinic out there, because I'm sure there's a lot of them that... I mean, we've both been trainers for some companies and seen the standard at the end of the course, and it's to the point where you don't get a certificate. So it's not like I can not sign them off. They've just done the course. I mean, you got courses with no tests at the end of them.
And I guess the other elephant in the room is credentialing and training certification. Like if you're a surgeon, there's a College of Surgeons. It's a bona fide body that's done that. If any other specialty in medicine, there's these sort of autonomous, sort of not-for-profit groups. Now, cosmetics is unique that it's got a few that call themselves a college, but they're actually, in my opinion, personal opinion, they're just groups of self-interested business owners that have called themselves that and really representing business interests.
Yes.
If you, like, I've tried to join some of them as a member and become a member, and I've actually been told that I can't tell anyone that I'm a member unless I've been with them for 3 years. So it does beg the question why you would be a member. It's not the behaviour of an organisation.
And did you get training for them for that price?
I paid $1,200 just to become a member, which entitled me to the newsletter.
Newsletter.
Yeah, I won't. There's a couple of them, so I don't need to name which ones they are in particular. But like if I become a trainee or a fellow of the College of Surgeons, I'm allowed to say that because it's a bona fide institution.
Of course.
So
and they'll provide training?
Yeah, and so cosmetics has got these sort of Mickey Mouse sort of...
well, look, there is no college.
Yeah.
I mean, look, they like to say they're colleges. Yeah. So at the moment, there's a million of them. There's probably 10 of them. There's probably more I don't even know of.
They're all various acronyms.
Various people saying that they are the president or they do not represent injectors.
They represent their business interest.
They do. And they run conferences for profit. What we are in dire need of is a college. We need a college that is recognised by APHRA, a training course that is recognised by APHRA, and Rob and I are the first guys to sign up for it, even though we've both been doing this for 10 years. we need...
It's long overdue. Yeah.
We need a credentialing service, and we need that for nurses as well.
And cosmetics is unique. It's one of the reasons I love it, that doctors and nurses, we do a lot of the same stuff.
Of course.
I find a lot of doctors get very threatened by that. They like to feel superior, so they hate it when there's a nurse doing the same job, often doing it better than the doctor. I love that. I embrace that. I think it's fantastic. But we still need to be credentialed. And
definitely. And I mean, like I said before, some of our best injectors, they're nurses. They do very well. They get incredible retention rates, so patients love them. They get great results. Some of our best before and afters are from nurses. But it's because we have self-regulated here at Contour. We do at least a minimum of 10 hours of live teaching a week. We have a capabilities checklist, and myself as the medical director sign you off on every single thing that you can do. So you know that when you come here, you're being treated by someone who's been signed off. We have a wealth of information, a wealth of kind of knowledge here. We have dermatologists involved, plastic surgeons involved. For our intimate area, we've got urologists involved. We are trying to do the right thing here. We are self-regulating.
We're setting the standard.
We are setting the standard, but I definitely welcome APHRA to mandate some of these things.
My background is surgical, as is yours, and one thing we do every single month is sit around with everybody, and it wasn't name and shame, but the morbidity and mortality meeting where we go through the either sort of formally reported complications or self-reported complications were discussed, and there'd be recommendations made, above all be learning, so we can try and not make the mistake again. I can't think of enough. Like you and I both know many other clinics. We've got friends in the industry.
All of them, yeah.
How many of them do a monthly M&M like ours is next week?
Zero. Yeah, we've got one next week. Complications happen in cosmetic medicine. It's just, even if you go and get your appendix out, one in so many will get an infection, will need a reoperation. That's medicine, unfortunately. There are risks and complications. And that's one reason why I think you need a doctor on site, because some of the complications become medical, they become infectious, they're things you don't get trained to treat as a nurse. You get trained to administer the medication, but not to make a treatment plan. We also don't have any kind of oversight in terms of, is this clinic doing something wild? I mean, say for instance, if Westmead Hospital, every second appendix operation was having a major infection requiring RCU, the medical board would get involved and say, hey, what are you guys doing?
There's lots of things that get reported in the background that you wouldn't even realise.
Currently, we don't have that.
Yeah, we do at Contour Clinics. It's one of the reasons I love working here. And I think that we've got this sort of culture of openness. We're not sweeping things under the rug.
Exactly.
We admit that mistakes do happen.
Definitely.
And, it makes us a better group as a result. And I think our patients recognise that.
I mean, look, there's a lot of arrogance in this industry, and arrogance will stop you from learning.
Imagine if we had a college of cosmetic medicine and every clinic had mandatory reporting of how many vascular occlusions.
I would welcome it.
Wouldn't that be an amazing thing we could all learn?
It'd be amazing. And I mean, we're doing things like we're writing papers on some of these complications, where we're doing audits of how many of these do we have.
We're going to meetings overseas, in Europe, around Australia.
We present at international conferences on some of these complications. And what I like to do is go back and it allows me to go back and do an audit of some of these practices. So say, for instance, there's a complication if you get facial slimming done. So it's a treatment that treats the masseters. It's one of the muscles involved in chewing. If you put some Botox in it, it slims it somewhat. Very, very rarely, about 1 in 200 cases, it affects the muscle that comes across to the smile, and it can cause a slightly asymmetrical smile. I'll go back through. We'll do an audit of our morbidity meetings, and if I look at the literature and it says 1 in 200, and then all of a sudden ours is 1 in 20, we go and we train all of our staff again. So we put action plans in place to make sure that we are the leaders when it comes to safety. It's great for patients. It's great for me because I don't like sitting across from an unhappy patient.
No, who does? I certainly don't.
It's not a very nice place to come to work. And when you come to a place like this, you spend very good money to look better, to get more self-confidence. You don't want to come to a place and then you have an asymmetrical smile for the next 2 months and it just robs you of your confidence. So look, these things happen, but we think that it should be mandated that these things happen. So, and we're happy. Any clinic out there that wants to see our protocols, that wants to see how we run our morbidity meetings, we are more than happy to share it.
Invited guests are very welcome.
Yeah, I want the entire industry to improve because at the moment I'm seeing some. I mean, I saw an Instagram thing the other day with a fat dissolving injection I sent you.
That needle was very well at the sides
and
very deep.
You had no idea where it is. And I just think a course that mandates this kind of training, that has someone with greyer hair than me signing you off, I think that's needed because, I pray for that poor woman that had that injection because God knows where that treatment went. I've seen other ones where they do filler into the back of the hands, and I spent a bit of time in hand surgery when I was a junior trainee. Well, this one's a little bit banged up after laser, but it looked like she was sticking it into the tendon. So they're simple, and this is another thing. Doctors versus nurses. Doctors, tendons are very important. You get any infection in that tendon, that's a disaster. That's like a surgical emergency. Yeah. If you're a nurse injecting alone in a clinic without... Because see, for us as doctors, we'll learn 1,000 things that just go without saying. Don't inject over a joint. Don't inject near a tendon. Yep. Don't do those things. They're basic things for us because we've had 6 years of training on them. I love nurses injecting. They need more oversight and they need a mandated course to go through. They need to be signed off on all these things because it is the Wild West at the moment. And the last thing I want to see from APHRA is more bureaucratic paperwork. I do not think that helps the patient at all. Doing more forms, more paperwork, or look, I got to say, all you're going to do there is you're going to tick a box to make it look like you've done something, but it'll make zero change to the industry.
And this industry needs real change. About that, I think, from the review with APHRA, like they probably jumped up and down and complained quite a bit.
Yes,
and perhaps they're regretting that now because there's a lot more things they need to do.
They're absolutely regretting it, and I would love to see an audit on safety 2 years down the track to see if that made any difference.
It'd be interesting to see.
It would be very, very interesting to see because from what I could see, we didn't have too much follow over because we're a cosmetic medicine, not a cosmetic surgery business. But the only thing that's changed in our clinic is more paperwork. From the audits that I've been doing, there's been no change to patient safety. But in saying that, we were already self-regulating. So we were already doing everything by the book. We already stayed in our lane. We had plastic surgeons, dermatologists, urologists. Only doctors do the advanced areas, nurses. So it may be perhaps a little bit unfair in saying that because we were already doing everything properly.
We spoke about before the show, I didn't want to just come today and just whinge about things. And I think it's been good. We've covered sort of a lot of the issues, but then some practical solutions that can be taken forward to try and improve the industry. I think it's worth pointing out that APHRA's basically just had the media release on the 5th of September that said it's coming, public consultation, ahead of the guidelines being reduced next year at some stage.
Yes.
So we're probably a little way off it, but
we are.
But look,
that's a really good point because there is an opportunity for you as the public to go and make some submissions. There are a lot of people that have had some bad experiences out there, and just discussing those, putting a submission in. I think that would be very, very reasonable.
Yeah, so thanks very much for the chat today. I think we've covered a lot of ground. We haven't just been whinging and complaining. We've got some actionable things.
We do.
But like you said, I think it's over to the public, really, because if the public has bad experiences, they should share with us.
Yes.
They can write to APHRA, write to us. Just conversations about this stuff is healthy, and hopefully we can work together to make a safer world in cosmetic injectables.
Definitely. No, look, I think that's a very good point to end on. So thank you very much, everyone, for listening to the podcast. Any questions about anything that we've sent, feel free to visit our website, www.contourclinics.com.au, leave a message, and we'll see you next time.